Alrighty. And push it all through there.
I just have to stand here.
Yeah, I think so. Yeah, just right. Awesome. So yeah, when you're ready.
Right, guys, we might make a start. So my name's Rohit. I'm one of the BMed Sci students. I'm doing a BMed Sci neuroradiology at Epworth. So I'm talking to you about ophthalmology today. So there's a lot of slides, many of you would have seen 204 slides, but the content is really not that much. The key about, I mean, we don't have talks on derm and ENT, but the key that you need to know is there's a lot of conditions. You don't need to know a lot about them. You just need to know the key differentiating factors between some of them that are similar, and that'll pull you through in the exam. In terms of what you're expecting on the exam, you're expecting about maybe 10 questions on ENT, derm and ophthal, including pictures, and you're also expecting one OSCE station. So although everything by itself is low yield, if it turns up on an OSCE station, it suddenly becomes very high yield. And our OSCE station last year, although I can't say what it was about, many of you may know, it was on a very low yield topic that's extremely rare in the community. We start to know a fair bit about it. So I'll go through the pathophysins of stuff that I think is more OSCEable, but otherwise probably don't really need to worry about it too much. So in terms of resources, the Golden Eye Rules are on Moodle. They're a pretty good resource. Ophtho book by Tim Root is also a really good resource. The INE lecture slides, if any of you guys went to those lectures at the start of the year, they're available on Facebook. There's a Google Drive up there. They're worth looking at. And iWiki is kind of your gold standard thing to look at if you're confused about anything. Every time you see a little Snoopy dog, that refers to some of those golden eye rules that will pop up every now and again. So how we'll divide today, we'll just talk about anatomy first, so just some very quick, just making sure everyone's on the same page. We'll go over some of the external eye conditions, and then the anterior eye conditions, the posterior eye conditions. I think those are worth breaking down in that way. It's good to not think about in that vitamin C type of categorization, but think more anatomical. So when we look at external eye conditions, there'll be things that affect the external eye. Anterior eye conditions will be things that present with redness and pain of the eyes. And the posterior eye conditions will present with loss of vision, whether that be bilateral in chronic circumstances or acute unilateral, okay? And then neuro-ophthalmology is kind of your walk in the park of third year we did last year. And again, that's more loss of vision, double vision type of thing. And then we've got a little bit more that I'm not going to cover today. So just a note on the slide, everything that's in red is worth knowing. Those are your so-called buzzwords. And I've got some key differentiating slides that'll help as well. So we'll move on to the anatomy. And I've divided this talk into cases. So there's probably about 50 of you here. You're all going to go. If you don't understand it, you can cheat because I think the slides are online anyway. But if you don't know, that's fine. So the anatomy. So looking at the external eye, I think the important things to note are the tear grants, the tears made in the lacrimal sac, which is in the lateral part of the eye. And as you blink, the tears move more medially into the canthi and then drained by the lacrimal sac into the nose. So on this picture, where's the conjunctiva? Anyone want to know? Anyone want to guess where the conjunctiva is? I could start picking people, but I mean, half my Vesper's here, so I don't know half the other of the other guys. How about the guy running for social rep next year?
Yo, what's up?
Yeah, I'll endorse you publicly if you can give me the answer to this. Pressure's on. Yeah, so where's the conjunctiva in this picture? Yeah, more detail. Whereabouts exactly? The white part is correct. That's part of the conjunctiva. Yeah. So it's underneath the eyelids and it's all over the eye. Okay, so the conjunctiva is this thin membrane. You can't see it. My mouse come up? It does. So it's this whole area over here and under the eyelids, right? So that's the reason why when you have something in your eye, it doesn't go back into your brain, right? The conjunctiva is there to stop it from going back. So importantly, if you have a conjunctivitis, which we'll talk about later, it not only affects the outer aspect of the eye that you can see, but also if you invert the eyelids, you'll be able to see some changes there as well. So that's important to remember. So moving on to the external eye, we have some glands. We have the meibomian glands, which are on the inside of the eye, and we have these other glands, the gland of Zeiss and Moll, wherever my pointer is, here and here, on the inner aspect of the eyelid. So what are these glands? They also secrete similar things. What do they secrete? Just basically. So they secrete oil. Why would you bother? Yeah, evaporation also prevents the tears from just spilling down your face, right? So it creates a film over the tears. So keeps your eye nice and hydrated and also keeps them from just spilling down your face. So those are important glands to remember. Moving on to the eye as we know it, and there's a lot of things here, but I think the important thing to remember is the cornea and the sclera are continuous. The cornea is obviously see-through, but they're all made out of the same type of collagen. We also have the episclera as well, which is just a thin membrane just on the outside of the sclera. Looking at the cornea in more detail, there's a few layers. You don't really need to know them in any specific detail. Just know that there are layers and they do exist. When you have, I guess, an injury to the stroma, that's when you get scarring. Okay, so that's important. And when you get injury to the epithelium, that's when you can stain it for fluorescent. So where does the cornea get its nutrients from? It's avascular. Yeah, so the vitreous or the aqueous humor, right? So any sort of humor, aqueous in this case. So speaking about that, we have two cavities, all right, in the eye, but we have three chambers. That's worth knowing. A lot of people think we have two chambers, but we have three chambers. The anterior is divided into the anterior and posterior chamber, depending on where it is according to the lens. And then you have the vitreous chamber, which is the posterior cavity. And they're filled with aqueous and vitreous humor, respectively, okay? Moving to the anterior eye, we have the lens, the iris, the ciliary bodies, and ligaments. That's all fairly straightforward. The lens has many layers, don't need to really know them. And the ciliary bodies have this paradoxical contraction mechanism of how they dilate the lens. And last thing is the retina and the choroid. So the retina and the choroid are the posterior aspect of the eye. And looking into more detail, the choroids at the back, and the light has to go through all these layers to get to the photoreceptors, which are at the very back. The choroid only supplies, and you don't need to know any of these layers. I think only two layers are important. The ganglions, which are in the front, where the light has to pass through all of those layers, and the pigment cells and the photoreceptors at the back. So the photoreceptors at the back are supplied by the choroid, but the choroid doesn't supply the whole of the retina. What supplies the anterior 2/3 of the retina? If it's not the choroid. Does anyone know any other vessels that are in the eye? Vertebral arteries. Oh, retinal. Yeah, absolutely. Yeah, sorry. So retinal arteries, right? So retinal arteries supply that anterior 2/3. So when you have retinal detachment, what's happening is that your posterior part of the eye is actually dead because it's not supplied by the anterior retinal arteries, like the central retinal artery, okay? And Brush's membrane is another membrane that comes in relevance when we talk about ARMD, which is just in between the choroid and the retina. Last thing is obviously the fundus. So the fundus, they could ask you to look at one in an OSCE or even interpret one or do a fundus exam. So it's worth knowing this because they go into it in some detail in the GP tubes. So the nasal side and the temporal side are obviously not worth messing up because you'll get the wrong eye in the exam. Then we divide our vascular arcades into kind of our four quadrants: supranasal, supratemporal, infranasal, and infratemporal. Again, those are the four quadrants you want to be quoting in your OSCE if they're doing a fundus exam. And then it's worth knowing that the arteries and the veins are usually thicker, but they might not be in pathological cases. And zooming in, because a lot of people don't understand the concept of optic cup and optic disc, and that's fair enough. So the optic disc is this whole nerve that comes out with the vessels that are kind of in the middle. And the optic cup is, if you look at this thing here, it's just this indentation. And this indentation is just where the ganglion cells are spreading out as they make up that, the outer aspect of the retina. And that indentation can increase in certain conditions such as glaucoma. So that's the cup. The disc doesn't change in size unless it's swollen, i.e. papilledema. Now moving on to the macula, we have the fovea. So the fovea just has all those cones. And that's the kind of the part of your vision where you don't want to lose because that's got the highest visual acuity. I will stop there. So external eye conditions. So I think we'll just go around the room because that's fun for me. So let's start with Michael. What have we got here? So we've got a man, and these are all questions that could come up in your exam. They're not unreasonable. A man complains of eyes feeling gritty and notices crusting in his eyelids. Diagnosis? Conjunctivitis? No, not quite. Yeah, blepharitis. So the key wasn't conjunctivitis, we're talking about external eye conditions. But yeah, blepharitis. So blepharitis is this chronic low-grade inflammation. It doesn't really do much. It just sits there. Can be due to, it's pretty much multifactorial. It can be due to blockage of glands or just inflammation of the hair cells. But I guess the classic symptoms that people present with on the exam is grittiness, flaking and crusting the eyelids, as you saw in this picture. The eyes, got all this crap all over it, and you can imagine that stuff flaking off in the morning. And you can get these secretions if the eyelid is actually pressed due to the unblockage of the glands that are blocked. You don't really need to give any antibiotics usually. Usually it's just caused by a non-infective blockage. All right, so we'll just keep going down. So our social rep guy again. So what do we think about this one? So a same man, he has a lump on his affected eyelid that should be affected, but it's not painful. Yeah, good. Yeah, chalazion, chalazion, whatever. Who cares? So it's a cyst that's caused by the blockage. So the blockage can just become a really big blockage, and because it's non-infective, it just becomes really big. It's not painful because it's not usually infective. So I think those are the two key things. So non-infective, sequelae of blepharitis, and it's not painful. Moving along, we've got this one. So a woman complains of a red lump, and this time it's painful. Yeah, it's a sty. Yeah, good. Or a hordeolum. So this one, unlike the chalazion, this one is an infection. It's usually on the outer aspect of the eyelid, as opposed to the other one, which is the meibomian glands, which are on the interior aspect of the eyelid. These are painful. They kind of look like pimples, and these patients may benefit from antibiotics because it's actually an infective process. So this brings us to our first key differentiating point. So as I said, everything you just need to remember very small bits about, and it'll make complete sense. So between these two, because they're confusing and may or may not have been relevant on the exam last year, you need to remember that the chalazion is on the outer eyelid, not painful. The sty or the hordeolum is on the outer eyelid and is painful, is infective. I don't know the best way to remember that. Maybe if you think like hordeolum sounds like Hodor, and Hodor's death was painful emotionally, then you'll remember that it's a painful process. I don't know. I couldn't. That was a spoiler alert, but everyone knows. So we'll move along. We'll just go up next row. An 8-year-old boy. This guy's probably a bit older than that, but he's got a fever and he's got tenderness and edema over one eye. No issues with eye movements. This happened after a sports day at school. This is a pediatric condition as well, not only GP. Yeah, that's right. Anyone want to help him out? Yeah, so that preseptal or periorbital cellulitis. Yeah, good. So what we define as a septum is a confusing topic. I've put in the red here. So it's kind of the tarsal plate and then the septum above and below it. So that's our septum. And periorbital or preseptal just means inflammation in this outer aspect of the eye. So just the eyelid itself, the outer aspect of the eyelid. And then postseptal is the eye and everything behind the eye. So obviously the one behind the eye is going to be worse. So preseptal cellulitis is just swelling of the eye, just like cellulitis in any other part of the body, redness, swelling, etc. But there's no problems with the eye itself. So the eye can move, the eye won't move with any pain. It might be difficult to see the eye because of all the swelling, but the eye itself is fine. Visual acuity itself is fine. And that's important to remember. You just treat these patients with fluclox, and it's usually staph. As opposed to this one, so a young child is febrile, has swelling in one eye, there's limited eye movements, and the child winces as they try to move their eye. So what did you think this one was? I'll give you another go. The other one was preseptal cellulitis. Yeah, just the other one. Yeah, so orbital cellulitis or postseptal cellulitis. So this one is usually due to an untreated preseptal or another infection around the face. It just goes back, and that obviously creates a lot of problems depending on how far back it goes. The key symptoms here are that it's painful eye movements. You still have the swelling and stuff, but the eye movements will be painful, will be limited. You might have limited visual acuity as well. Key differentiating factors between these two conditions. CT should be performed just because you want to rule out an abscess or some other problem, because these are all the complications that can happen. So this is your standard periorbital, then you have your orbital and goes all the way back. So you want to rule out these things because that can cause stroke and hemorrhage in the brain. And this is kind of one of the reasons why you want to do a CT, because you have all this gunk build up and you have this proptosis with the eye being pushed forward because of all the shit that's built up behind it. And proptosis is another symptom that you want to worry about. So again, the key differentiating factors, I'm going to repeat myself a few times because I want you guys to remember it. So the periorbital, you'll have swelling in both, but you won't have any problems with the eye in the periorbital. In the orbital, you'll have problems with the eye, and you'll have proptosis, pain on eye movements, etc. Okay? Key differentiating factors. All right, next one. A baby, another PEDS condition. So a lot of these will overlap with PEDS and whatever. Baby is very teary, say right after birth. And there's a lot of mucopurulent discharge in one eye. Yeah, so I'll give you that one. So it's definitely a cause of conjunctivitis. So this is nasolacrimal duct obstruction. And it happens in babies when a certain valve, this valve here, the valve hasn't opened. And to treat this, you just open the valve and you can just poke it open. And they get a lot of blockage, and with the blockage, they get stasis of the fluids that should have been drained out through the nose, and that fluid gets infected, and they get recurrent conjunctivitis right after birth. And it's also called sticky eye, which is the option that they've been using in the exams. So that's all you need to know about that one. All right, we'll move on. Just a spot diagnosis. Something you would have looked for in your cardio exam. Yeah, xanthelasma. Good. That's all we're going to talk about. It's boring. All right, anterior eye conditions. So moving back. So a woman complains of red eyes, initially just one eye, and then spread to the next one. She's had a lot of watery discharge, and she's got pre-auricular lymphadenopathy. Yeah? Give me a little more detail. Absolutely. So viral conjunctivitis is the most common type of conjunctivitis, usually due to adenovirus. Bacterial is more common in pediatrics because kids are weak in pretty much everything they do, and a lot of them Haemophilus influenza, so if they're from Brunswick and they haven't been immunized because their parents are idiots, that can be there. And also STIs can be passed down as well. So that's more of a women's PEDS type thing. So remember that it's the inflammation of the conjunctiva, which isn't just the redness on the eye, it's also the inner eyelid as well. So you'll see changes of these so-called papillae that you can see here as well. It typically affects one eye than the other. That's not a really good differentiating factor between viral and bacterial. You kind of want a little bit more information, and the more information you get of viral is the pre-auricular lymphadenopathy. That's definitely viral. Bacterial will have a lot more gunk coming out of the eye, so mucopurulent discharge. When they wake up in the morning, their eyelids will be stuck together. They'll have a lot of crap around the eye. As you can see in this one, this doesn't look too good. And it usually starts on one, moves to the other, but that's not reliable. You can also get, not any of us hopefully, but in Aboriginal communities and stuff, trachoma is a bit of a problem. And the TLDR of that is that you get a chronic inflammation that basically inverts your eyelid or your eyelashes, and they scrape against your cornea. That can cause blindness because that's obviously bad. You treat them viral, you don't need to treat them at all. Just maintain hygiene because it's quite, well, it can spread from person to person. Classically, travels in packs of families. And bacterial, you can use chloramphenicol, which is kind of the antibiotic of choice for everything in ophthal. So this one, a woman complains of itchy eyes during spring. His eyes are found to have a glassy appearance. Who we have two? Yeah. Yeah, that's you. Yeah. Yeah, allergic conjunctivitis. So just the other type of conjunctivitis. So it can be non-infectious, and classically, I mean, there are a lot of different types of conjunctivitis that are non-infectious, spring catarrh, etc. We'll just talk about allergic. The hallmark symptom is itching. The viral, the bacterial, they didn't have itching. They had pre-auricular lymphadenopathy. They had gunk coming out of the eyes. This one has itching, has glassy eyes, very watery, and can be seasonal. Can be associated with atopy, okay? The management is straightforward. As you advise someone for asthma or eczema, you want to avoid the allergen, and you can use antihistamine. And the one they like to name drop in the exam is this one here, which I won't try and pronounce. But that's the one you'll be wanting to use. So again, the key differentiating point between the three types of conjunctivitis, because they're confusing. Viral, watery discharge, pre-auricular lymphadenopathy, you don't need to do anything. You just need to maintain hygiene. Bacterial, you have the crap coming out of the eyes, the lashes will be stuck together in the morning, and you treat it with a topical antibiotic. And allergic, you have the watery discharge, itching, a lot of itching, seasonal, maybe they have eczema, maybe they have asthma, and you treat them with a topical antihistamine. Okay, so key differentiating factors again. So what about this one? So we have a man, he's poked in the eye after reenacting his favorite Star Wars scene with his imaginary friend. His eye is bright red. You think that no one does this, but there's this guy. So these people do exist. So what do you think the diagnosis is? He's quite skilled, except when he nearly falls over, but I watch this video on repeat all the time. Yeah, subconjunctival hemorrhage, absolutely. So these patients are classically have a history of trauma, but even more commonly just have a history of like bearing down on the toilet when they're taking a massive dump, and their eye just become red. I gave this talk to the Melbourne Uni students who are at Epworth. One of them related to having this every time he took a really big motion, which I thought I didn't need to know, but he felt like telling me. Interestingly, people who have amyloidosis, the most common form, they can get this particular kind of raccoon eyes, and it can happen the same mechanism, which is hilarious. Anyway, how these patients present. Bright red eyes, as we saw in the picture, it'll look like fresh blood. Over time, like a bruise, it'll become yellow, blah, blah, blah. So important to remember that. And it's painless, no change in the vision. So it's subconjunctival, it's not affecting the pupil in any way. And you don't need to do anything. Despite how bad it looks, it's not that bad that it needs something done to it. And all this increased venous pressure, so straining the toilet, vomiting, choking, coughing, sneezing, can have a lot of other impacts too. So you can have this problem in the retina as well, which is called valsalva retinopathy, or I like to think of it as a pokeball retinopathy. It looks very similar to pokeball. And I guess the take-home message is to not sneeze and cough, because it can really fuck you over. So that's what I learned from ophthalmologists when I did my ophthalmology clinic. Okay, next one. This is a straightforward one. So a man was doing work in a building site when he suddenly felt something in his eye. Yeah, foreign body, absolutely. So foreign bodies are, if you got this at an OSCE station, that'd be a blessing. So it can be a foreign body, it can be a chemical. So the chemicals is top picture here, where although everyone's looking at the one below it, but the top picture, you get this widening of the eye. So how you want to manage those patients is neutral. Again, I think one of the other students said that why can't we just give them a base if they have acid? You're not doing a titration. That's just stupid. You don't do titrations after you get 12. It's all useless knowledge. So you just want to flush the eye out. You don't know if it's a base or an acid, how strong it is. Just flush it out with water, okay? Just literally put a hose to their face. Like, you know, it'll be quite fun actually to do it. And with the foreign body itself, you can just hook it out, right? If it's just a superficial foreign body, not causing much scarring or anything, you can just hook it out as this person's doing here with a needle. And you might want to give them some antibiotics as prophylaxis to prevent any sort of infection. I think they do show you one of these in your GP lectures, but the guy actually misses once and pokes the eyeball. You don't want to be doing that. But yeah, so moving on to similar things. A woman had a red teary eye for a while. However, she has pain and photophobia in that eye now, and fluorescent stainings performed. Yeah, corneal abrasions. And what do you think the cause of the corneal abrasions might be? Like anatomical cause. What do you think? What's causing these abrasions? Sorry? Blinking. Yeah. So it's the eyelids, the eyelashes itself, right? So if you look here, you can't really see the eyelashes. They're probably all inverted, or maybe they're being removed now. When you have these linear patterns, you've got to be thinking of eyelashes. And one foreign body will not cause this sort of pattern. And if you had like 10 foreign bodies in your eye and you didn't notice, you're a bit of an idiot. Just putting it out there, that's probably true. So corneal abrasions. So you loss of that epithelial layer of the cornea, so the outer layer of the cornea. When that layer is lost, you can give fluorescent, and fluorescent will bright up like a Christmas tree for any of those areas that have no epithelium. So fluorescent staining is something that you'd want to be mentioning in endoscopy. And it's something that I think you guys did in tutes as well. So they wouldn't expect you to do that on a patient because that would just be torture for someone, but it's there. The clinical features are photophobia. Why would you get photophobia? You didn't get photophobia in conjunctivitis. What cranial nerve supplies the eye in that regard? Yeah, so it's cranial nerve 5, right? Which is why when you get herpes zoster, it screws up your eye, the ophthalmic division. So it's all cranial nerve 5, the same nerve that innervates the meninges, and you still get photophobia with meningitis, right? That's all. And furthermore, even with migraine, when you get photophobia, it's still due to activation of the trigeminal nerve. So trigeminal nerve is important. So diagnosed via fluorescent stain. Management is topical antibiotics. Obviously, stop the thing that's causing it. So if the eyelids are rubbing because you have trachoma or you have an entropion or something like that, you want to be making sure the eyelids are removed. So the eyelashes are removed, and stuff like that. We'll skip over these. So entropion, just speaking of that. So entropion is when your eyelids, your eyelashes kind of turn inwards, and then they can start causing linear abrasions over the cornea. And that's obviously not a good thing because as you keep going down, especially through the stroma, you start getting permanent scarring. That can cause vision problems as well. So this is a very classic Monash case. A man has a red painful eye, which has been getting worse over the last week. Fluorescent stainings performed. Who are we up to? Yeah. Have you done your GP rotation? It is keratitis. Yep, so it's HSV keratitis. Does anyone know the name of this? Maybe the person next to you told you the answer. You know the name of this ulcer? Anyone? Yeah, dendritic ulcer. Yeah, good. So definitely something that Monash expects you to know. I think they make a big deal out of this. So keratitis, just taking a step back, is inflammation of the cornea. Multiple factors involved that could cause keratitis. So remember the cornea is that outer part that right in front of your pupil, that part that's transparent. So the risk factors are prolonged contact lens use, especially someone who's gone swimming with contact lens. That's not a good way to, that's pretty risky. You can get amoeba and just eats out your whole eye, which would be good to see as a student, but not good for the patient. We should scrap that from the recording. Anyway, so trauma is another one. That's when you get your bacterial keratitis. Neurotrophic cornea, so HSV or even shingles can affect the cornea. And photokeratitis, so this is so-called the arc wielder's eye, or the person who's done a lot of snowboarding without wearing appropriate sun protection over their eyes, and they get kind of this blinded keratitis. So the classic features that people describe would be the sand pouring over the eye. That's how they describe the pain. And it's just over that anterior aspect of the eye. Again, it's a red eye. All of these anterior eye conditions all have a red eye, okay? Photophobia is the important symptom. None of the conjunctivitis, none of the subconjunctival hemorrhage, none of the anterior eye conditions had photophobia. Right? Photophobia is specific to keratitis and corneal abrasions, so corneal pathology, and reduced vision, obviously. The HSV keratitis presented with the dendritic ulcer, that's worth knowing. The other thing that's worth knowing is this little layer here. So this is called a hypopyon. This is pus in the eye, in the anterior chamber of the eye. And that's also specific for keratitis and some sort of anterior problem. So how you manage this? You give antibiotics for bacterial. If it's something else, you just get rid of that. If it's HSV or shingles, you give an antiviral, so a cyclovir. The important thing on the exam and the OSCE is to never give these patients steroids. So the steroids can actually increase the number of the viral load, and it can actually predispose to getting a corneal perforation, which is basically when the anterior chamber starts leaking out from the front of your eye, which would probably suck. So importantly, never give topical steroids for someone who's got viral keratitis. So we'll move along. So a surfer notices a redness in the corner of his eye. Any ideas? Pterygium or surfer's eye. So this is kind of a benign condition. So you get this red kind of fibrous, I guess, growth that moves laterally. That moves medially from, I guess, no, that's the wrong word. So it moves to the middle of the eye from each side, as you can see here. So they start off in the, where did my pointer go? They start off on the sides and they move inwards. They're not a problem unless they impede on this. So otherwise, you can just see it maybe in the corner of your eye as a redness is a classic description. But if they don't impede on the pupil, they're not causing any problems whatsoever. And usually they're operated on for cosmetic reasons, not for any other pathological symptomatic reason, okay? The management is mainly prevention further, so sunglasses, because UV light is the main predisposing factor to getting pterygiums. So buzzword there is redness in the corner of the eye. So we'll move on to, let's go in. Oh, we got one more person up there. So an elderly diabetic man has noticed gradual change in his vision. He's noticing a lot of glare and halos around lights at night. Definitely. So cataract's a really important condition, potentially osceable. So I'm going to go into a little bit more detail. So we remember that the lens had different layers, and those different layers can be affected by cataracts. The nuclear, which is the middle of the lens, is the most commonly affected, but the cortical areas can be affected in diabetes as well. The most common cataract is this one here, which is a nuclear one, which is very brown, but they come in all shapes and sizes, the Christmas tree, the firework, the Mitsubishi sign. So these ones are called rosette cataracts, and they're usually sequelae of trauma, but Mitsubishi sign's way better. The main risk factor for these for people with cataracts is obviously advancing age, and then UV light and diabetes, right? Those are your three risk factors you want to be thinking about. A lot of other things, so corticosteroid use, blah, 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 but the main ones are aging, UV light, diabetes. And congenital cataracts do exist as well. So in babies, someone with congenital rubella syndrome on your pediatric exam might have cataracts. The symptoms were pretty much as the question said, so gradual decrease in visual acuity, not usually localized to any specific area, just generally gets more fuzzy, glaring of the lights, and halos of the lights at night is also very important. And also the loss of the red eye reflex. So when you do the red eye reflex, why is it red? You want to know why it's red? Yeah, it's coming off the retina. And if you have something that's blocking anything from the lens to the retina, including the lens, then you can't see the red eye reflex, okay? So you get leukocoria, which is the white eye reflex, or the lack of the red eye reflex. So that's because the light can't get through the lens. That's kind of what you'd see. So it's just general blurring, not really visual field loss per se, but just a decrease in visual acuity. And surgical therapy is the only therapy. No medical therapy is proven to work. And it's a very quick procedure. I'm sure that in GP she would have showed you some videos and they just do it in like, I don't know, 2 minutes. All right, it's another one. So we'll move on to this side for Nadia. A man has been hit by a squash ball in the eye. So squash balls are the same size of the eye socket, very dangerous. He presents to the ED with a red eye. Yeah, good. Hyphema. So hyphema is red blood cells, like the hypopyon, just blood cells in the anterior chamber of the eye, usually from trauma, but it can also be iatrogenic. And this is a big problem because the blood can just continue to build up, and then it causes massive increase in intraocular pressure, and things start breaking inside the eye, which is never good. So the key differentiating point between the conjunctival hemorrhage, which was the lame kid playing, Star Wars by himself, and hyphema, someone who's playing squash or some other respectable sport, is that the conjunctival hemorrhage is benign. It's located to one area of the white part of the eye, And the high femur is not benign. It's a surgical emergency, and it's a layering of the eye, just like you'll have pleural fluid on your x-ray. It's a similar sort of principle, right? That's important to remember. You must refer those patients. So moving on. A young man presents with eye pain after having worsening lower back pain for the last few months. Yeah, good. Anterior uveitis. So anterior uveitis is inflammation of the uvea, and I didn't talk about what the uvea was because it's not really a thing. So it's kind of a collection of things, including the iris and the ciliary body and the choroid. But when we talk about anterior uveitis, we just mean really the iris and the ciliary body. So it's also sometimes called iritis. And it's usually caused by, it's usually associated with those HLA-B27 conditions. So ankylosing spondylitis, which this patient might have had, or psoriatic, or enteropathic, or Reiter's syndrome, one of those four. But also other autoimmune conditions. The classic symptom you have is limbal flush. So the limbus is kind of like this area just around here, and that's the eye. That's the part of the eye that's very red. The rest of the eye might be a little bit red, but that's the prominent part of the eye that's red. Limbal flush. And you can also get some other things as well. So some visual problems. You can get these precipitates here, which just because everything's inflamed and little bits just start coming off, and those are the precipitates. You can get this thing called posterior sneaky eye, which is important to remember. We'll talk about glaucoma later. So where the iris actually gets stuck to something posterior, and the thing posterior to the iris is the lens. So it gets stuck to the lens, and as it gets stuck to the lens, it has this irregular appearance. Where'd my pointer go? It has this irregularity here, so posterior sneaky eye. You can also get the lens pushing up against the anterior part of the eye as well, and that's called anterior sneaky eye. But this is obviously important because the drains through here, so it can't drain if you get posterior sneaky eye. We'll come back to that later. And also with this patient, you notice that he's also got the hyperpion. So anterior problem, that's how you know. So young woman presents with redness and aching on one eye. Let's call it a moderate aching. The redness is located in one sector of the eye only. Yeah, episcleritis. So episclera was that thin layer just above the sclera. Usually it's idiopathic, hence non-infective. You get this moderate aching, redness in one sector. So in here, it's just in this medial part of the eye that's red. This part's okay. That's important. The pain's not too bad either, and it's also benign, and that's worth knowing. I think in one of the past papers that the faculty released, they actually asked about management of episcleritis. They gave you a picture, and they asked you the management. The management is nothing. You don't do anything. It's fine. I think someone actually posted the wrong answer on those CAMI documents, so watch out for those guys. Some of them are dodgy. I won't say who, but some of them just didn't know their stuff right. So this is as opposed to scleritis. So we had episcleritis sector. Scleritis is everything's involved, and it just looks really bad. So the sclera is just the part under the episclera. It's usually, again, non-infected, but it's the whole eye. It's diffuse. It's very red, very painful. So again, key differentiating point between three causes of a red eye beyond the cornea and the conjunctiva. Anterior uveitis has that limbal flush, posterior sneaky eye, precipitates, is painful, and also associated with those 4 HLA-B27 rheumatoid conditions. Episcleritis is just one sector, and idiopathic will go away by itself. And scleritis is this diffuse redness, very painful, and does need steroids to manage it. So important things to remember. All right, so just another spot diagnosis. So mother and a child, the mother's on top. Both have had multiple low impact fractures. Who are we up to? Yeah. Yeah, who cares? Yeah, osteogenesis effect. Don't admit. Next time, just be like osteogenesis effect. Obviously, like just establish your dominance here. That's like half of med school, isn't it? Like someone just putting their hand up in a tutor to show that they're smart. I hate those douchebags. So definitely osteogenesis effect. Blue eyes, right? And the history of fractures. Not blue eyes, sorry, blue sclera. And the history of osteogenesis imperfecta. Makes sense. And this one, moving down, spot diagnosis. Yeah, KF rings, very rare. You probably never see them. So that's copper deficit. So what's the problem with Wilson's disease? What's the deal with that? What's the pathogenesis? Obviously, it's some genetic thing, obviously, but what's the problem? Yeah, how does that happen? Yeah, so you have decreased ceruloplasmin. Ceruloplasmin intakes the copper into the cells, utilizes it and stuff. You also have just decreased copper coming through the bile salts. So you have too much copper, so it can't get incorporated to the bile salts, so it can't be excreted. So you have too much copper, and in this case, in the eye, it builds up in one of the membranes of the cornea, just the last one, Descemet's membrane in the cornea. Sorry, the second last membrane in the cornea, which causes these Kaiser-Fleischer rings. And last one, that's a spot diagnosis. I'll open this one up to anyone, it's a little bit hard. Yeah, which one? 1 or 2? Yeah, 1, because 2 is optic, those acoustic neuromas or acoustic schwannomas. So this is Lisch nodules, benign lesions of the eye of NF1. I think it came up in one of our pediatric revision lectures, so I thought I'd include it. All right, so moving on to the posterior eye. So everything we've done so far is painful eye, red eye, okay? These ones are gonna be more visual loss. If it's chronic, it'll be bilateral. If it's acute, it'll be unilateral. And you'll get lots of pictures of retinas, such as this one. So an elderly man notices he's having trouble seeing things, especially in the center of his vision, bilaterally. Yeah, absolutely. Age-related macular degeneration. So as the name suggests, it's affecting the macula and it's advancing age. You have 2 types. You have the dry type and the wet type. So I think the diagrams makes it better. You have this, in the dry type, you have something called drusen, and drusen builds up between the retina and Brush's membrane. So Brush's membrane was that membrane in between the retina and the choroid, and you have this drusen that builds up. What drusen is, no one's really quite sure. It's some eosinophilic protein, and it's got a lot of fat in it as well. No one really knows what it is and how to stop it from building up, which is a shame because we can't treat it properly. But that's what happens in the dry type. So you have this buildup underneath the macula, and as it builds up, obviously you're going to decrease your visual acuity of your macula, which means central vision loss is going to be mainly affected. In the wet type, which is a sequelae of the dry, you get the vessels coming through the Brush's membrane and into the vitreous, and that can cause a whole lot of problems as well. But this is a sequelae of the dry type. So the clinical features are mainly involving your central vision, and as you would look in an Amsler grid, you get this swirly appearance of the central part of your vision. The Amsler grid's kind of the diagnostic tool, the classic diagnostic tool that people would use to diagnose this. So this is very classic. So the wavy appearance of the Amsler grid. Also, you can get some scotoma and difficulty reading and stuff like that as well. That's kind of what it would look like for someone with quite severe degeneration. In terms of management, there's not much we can do because we don't know how the drusen works, so we can't really do anything to stop it being produced. So some people say that high antioxidants or certain vitamins can help, especially vitamin D. The wet type we can do something for because we know that the problem is neovascularization, and we can actually stop vessels from getting formed by using anti-VEGF agents. So anti-VEGF agents will work in numerous conditions where you have neovascularization. It's also used in many cancers as well. So if we can stop the vessels growing, we can stop them from spreading through the vitreous humor and causing more problems. Because as they spread through the vitreous humor, they'll rupture or they'll go all the way to the iris and then they'll cause glaucoma. But we can stop all that happening as we can do in proliferative diabetes, then we can help these patients a fair bit. So what about this one? An obese elderly woman who's recently arrived from a war-torn nation as an asylum seeker. She has cataract and no other visual complaints. This is a retina that they somehow got through the cataract. Yeah, good. Diabetic retinopathy. So diabetic retinopathy is another big condition that could come up and ask you if they show you a picture because it's so characteristic. A lot of things go wrong, but I think it comes down to exudates and hemorrhages. And if you just remember exudates and hemorrhages, you can kind of figure out what else is happening. So hemorrhages of all different types, exudates of all different types. And then in the proliferative stage, so diabetic retinopathy affects not so much the choroidal vessels, but more so the vessels that supply the anterior 2/3 of the retina, right? So the vessels that come out of the optic nerve sheath. So as those vessels die and involved in diabetes, the choroidal vessels must do more to supply, right? Does that make sense? So they move forward and they neurovascularize anteriorly. Okay, they go through the retina and they start doing exactly what they did in the wet type of ARMD, okay? They go into the vitreous, they rupture, they cause all sorts of havoc, and they just fuck shit up. So that's the importance of, again, neurovascularization is the proliferative form, and you treat it the same way. You treat it again with anti-VEGF agents. This is probably the only page I looked at of Davidson's. It's got this massive explanation of stuff. I'll leave that to you to read. This is when the neurovascularization affects the iris. And as you can see here, we've got an irregular shaped pupil because it's kind of stuck to the iris, and that causes glaucoma. But that's very severe. So management, again, better diabetic control. We can do photocoagulation. The characteristic picture here is all these dots. So all these dots are lasers, and what they're trying to do is each laser is going to kill off the vessels that are new growths. Obviously, you can't kill off this area. That's what the macula is, right? So this is not a curative kind of procedure. This is just more preventing more damage. It's more damage control rather than stopping the actual growth of the vessels. And importantly, that this condition is asymptomatic until it's too late. So important screening is really recommended. So that's more your Murtaugh's 10 steps and stuff. So another one. A man presents to his ophthalmologist, follow-up regarding his open-angle glaucoma. He has a history of hypertension and no history of diabetes. Who are we up to? Absolutely. Hypertensive retinopathy. So hypertensive retinopathy, we can divide into, there's 4 stages, but I guess we can divide it into 2 main groups, that being acute and chronic. So in chronic hypertension, we get these silver wirings, and we can see this here in this bottom picture. So what the silver wiring is, all that white stuff, that's all atherosclerosis, right? It's all crap in the vessel. That's why it's white. That's why it's silver. That's the silver wiring. And we have this AV nicking. So AV nicking is here. So usually our veins are darker than our arteries, right? So this is a vein here, and this is an artery here. The artery is really stiff. It's kind of blocking the vein in one area. So the vein kind of looks like it's nicked off at one part. That's AV nicking. So these 2 things are characteristic of chronic hypertension. You don't get atherosclerosis of the whole vessel in the acute phase. In the acute phase, you get papilledema and blindness, and this can be quite severe. Importantly, note that a lot of these changes are reversible if you just manage the hypertension. Everything just goes away. Unlike diabetes, unlike ARMD, you can't reverse those changes. So the key differentiating point between 3 causes of bilateral vision loss. Dry ARMD has the drusen, right? These characteristic drusen lesions, get the squiggly line in the middle of your vision, decreased visual acuity. It's not reversible. Diabetes, it's asymptomatic until it's too late, okay? You get exudates and hemorrhages. Again, it's not reversible. And if they give you a history of diabetes, you'd be stupid to pick something else. Asymptomatic for hypertensive retinopathy, again, if it's silver wiring, AV nipping, or AV nicking, sorry. So the problem is that you're having atherosclerosis, and it's reversible, even in the later stages. All right, so move along. So unilateral vision loss, an elderly woman, sudden loss of vision in one eye, no pain, no redness. The medical team is unremarkable. She had a TIA last week. Central retinal artery occlusion, absolutely. So this is basically a stroke of the eye. So the central retinal artery gets an embolus thrown right at it, and it causes acute vision loss in that eye. Monocular vision loss, okay? The fundus is very characteristic. So you get pallor everywhere. You get this boxcar segmentation of the vessels because you can't get any collateral supply here. The only collateral supply is back up from the choroid. So everything kind of looks like it's not very well supplied. And the veins might be more prominent because they can't drain properly, or they don't have anything to drain. And you get this cherry red spot, which is just basically we're seeing the pigments underneath the macula. So that's the problem there. Very characteristic. And the management is complicated, but basically you want to drop the intraocular pressure or dislodge the emboli. So you can rub the eye and massage it, and that can dislodge the emboli, or you can give mannitol and you can take out the fluid to reduce the pressure, etc., etc. I don't think you need to know that. So another one, person in blue. So an elderly man reports sudden unilateral blurring of vision, history of diabetes and hypertension. His eye is not painful or red. But that's his fundus. So we just did central retinal artery occlusion. Yeah, pretty much. Yeah, it was out of vein and lymphatics, and who cares about lymphatics? And they're not there anyway. So the central retinal vein occlusion. So to cut a long story short, how the occlusion happens is that you have a lot of, just imagine a patient with a lot of cardiac risk factors, so diabetes, hypertension, advanced age, blah, blah, blah. And basically what happens is that you have a really thickened artery, and the thickened artery impedes on the vein that's coming out through the optic sheath and through in the middle of the optic nerve. And as it impedes, it causes stasis of the blood flow just behind it. Stasis, as per Virchow's triad, can cause thrombosis. Thrombosis happens via that mechanism. It's always due to the artery. Or maybe you have some other hypercoagulable state or cancer or taking the OCP or something like that. Virchow's triad comes back. It's usually, again, painless acute, usually slower than the stroke, than the central retinal artery occlusion. The fundus is characteristic. They call this the blood and thunder fundus, right? Very characteristic fundus. Why? Because you've got a problem with the vein. You've got a blockage of the vein, so it can't drain. So where's the blood going to go? It's just going to burst out everywhere all over the retina. So you get hemorrhages in all 4 quadrants. We're looking at your vascular arcades, it's everywhere. There's branch occlusions as well, similar thing. So branch occlusion will just be one quadrant, and the hemisphere, hemiretinal occlusion will be half of it. It's all the same principle. It's usually due to the artery causing stasis or blocking off the vein, and then that causes hemorrhages, right? So important to remember. So the key differentiating point between these two, because again, they're confusing. This is sudden monocular. This is monocular as well, but it's usually less sudden. Retinal pallor, blood and thunder fundus. You can't mix these two up, right? And the cherry red spot and more hemorrhages, right? 2 completely different retinal pictures for the same presenting complaint. Okay, so next one. An elderly woman is known to see floaters in her vision for the last few years, which is normal for most people. For older people, she notices an increase in the amount of floaters. As she's taking the ED, she notices a dark shadow moving over her vision. We're up to front row. Yeah, we'll go, yeah, retinal detachment. Yeah, good. So I think we touched on retinal detachment earlier. A lot of text here, I can't be bothered reading it. So basically what's happening with retinal detachment is that, as the name suggests, funnily enough, the retina detaches off the choroid. And as it detaches off the choroid, the back third die, right? It's supplied by the choroid. Your photoreceptors aren't supplied, they die, which causes your visual problem. They're still connected to the ganglion cells, but the reason why you're not getting visual vision there is because they're dead. So you can't actually get the signal going back up to the ganglion cells. So usually what happens is that you get these, and in age, this is all common, you get this posterior vitreous detachment. What that means is the vitreous is like a jelly. And as you age, part of the jelly becomes a little more liquid. And as it becomes a bit liquid, it kind of creates a vacuum on the retina, pulling it. Usually it doesn't pull it to a degree to detach it. You just pulls it and you get a bit of floaters and some gunk that comes out from the retina. Sometimes though, it can actually pull the retina enough to tear it. So here it's pulled, but nothing really happens. And here it's pulled and it's actually torn the retina off it. And as you tear the retina, you get ischemia, and then you get your visual acuity, your visual field defect. So you get the prodrome of vitreous detachment, posterior vitreous detachment, which is the flashing of lights, more floaters, etc. And then when you get actual detachment of the retina, then you get visual field problems, okay? You can ultrasound them. How you manage these patients is basically you want to do the opposite of what you did with the central retinal artery occlusion. You want to kind of increase intraocular pressure and push the retina back on. So you can either do that by putting some air in and physically moving the retina into the right place, or you can kind of buckle it together and hopefully this part connects back to this part, or you can take out some of the vitreous and try and do the same thing. So again, key differentiating factors. In PVD, posterior vitreous detachment, you get no visual field problems at all. You just get the floaters, you just get the photopsia, but no visual field problems. In retinal detachment, the retinas come off, the cells are dead, you'll lose some part of your vision. And that's important as well. And again, it's usually in one eye at one time. Just having this is not a problem. It's not an emergency. This is common. Older people will have this all the time. You ask your GP tutors, who are all close to the end and the start, they'll all have this. It's true, isn't it? Like 50 is kind of the cutoff. They're all over 50. It's not controversial. It's true. All right, so it's a bit harsh, but it's still true. A young person who has been progressively losing peripheral vision sees the ophthalmologist. Her mother also had tunnel vision before she was killed by a gorilla taking revenge for Harambe. Rest in peace, my friend. So what do you think this patient has? So this is probably a tough one. These are bone spickled lesions in the peripheral. Yeah, good. Confident answer. Retinitis pigmentosa. What a beast, guys. He's the guy to beat, you know? He knows that. Retinitis pigmentosa. It's a hereditary condition. Do we really know how it works? No, really, it's about the rods. The rods, remember, are the peripheral part of your vision. And apparently what happens is that as they break down, they're not cleared. And the breakdown products are these bony spicules around here in the peripheral part of the vision. Kind of makes sense to a rudimentary degree. The key features here are tunnel vision and loss of vision at the nighttime as well. Your important differential for loss of nighttime vision is vitamin A deficiency. Yeah, that's all you need to know. And friendly now, vitamin A therapy helps them. So tunnel vision. All right, another one. An infant is found to have leukocoria by her GP. So the loss of the red eye reflex in one eye. Yeah, retinoblastoma. So the most common cancer in kids in the eyes. If it's hereditary, it's both eyes. A lot of the time, you just have to take out the whole eye. So if it's hereditary, it's bad news. But yeah, loss of the red eye reflex is really important. So this is a normal red eye reflex. The retina is right behind it in its completion, and it's coming right off it. In this case, we've got in the other eye, we've got something blocking it, i.e. a tumor, and it's the loss of the red eye reflex. So what's the most common primary intraocular malignancy in adults, though? So they don't get retinoblastomas in adults. All the blastomas are all kids. Yeah, melanoma, absolutely. So melanoma, when you're doing if you ever have to do a derm exam, look at the eyes as well. This is just a quick case. So pale-scented hemorrhage in an IV drug user. I think we're back to. We haven't done U2 at the back. What do you reckon? You look for it in your cardio exam. You say you look for it, but you don't have a fundoscope. It's a sign of infective endocarditis, you know? Yeah, so Roth spots, yeah? So something you look for, or you say you look for in your cardio exam. All right, so looking at some revision of third year now, so I don't know how we're going for time. Can't be too bad. Oh, it's going on. So neuro-ophthalmology kind of goes over three areas. So vision loss, pupil abnormalities, which we're not going to talk about too much, and then double vision, so cranial nerve problem. So this condition I could have put in the anterior eye because it's probably more relevant there, but I put here for a specific reason. Very oscable. So an elderly woman was watching TV in a dark lounge room when her eye suddenly became painful, so one eye. Her husband rushed her to the ED where the eye was red and had a mid-dilated fixed pupil. So the person at the very back behind Nadia. Just one eye. Any ideas? Anyone want to help her out? Yeah, glaucoma, right? Acute angle glaucoma. So glaucoma is an important condition to know. Again, I think it's very oscable. So this was the eye that was affected here, and the mid-dilated pupil. Talk about that in a second. So glaucoma I've included in neuro-ophthalmology because it's really an optic nerve problem. The whole point of the optic disc and the optic cup is that the nerve dies due to increased intraocular pressure, right? So it's really an optic neuropathy problem. So I guess what's important to know is how the aqueous humor drains and the vitreous humor drains. So it comes out through behind the iris, between the iris and the lens, and then it drains via Schlemm's canal, and just basically drains via that. Little bit drains over here, but that doesn't really matter. Importantly, it has to come through behind the iris, around the lens, and then into the anterior chamber of the anterior cavity of the eye, okay? So that all needs to be intact. In glaucoma, there's a problem there. So in open-angle glaucoma, which is the chronic one, not the one that this patient had, you have a problem with the trabecular meshwork where it's just kind of blocked in some regard and it can't drain properly. It still drains, but it doesn't drain properly or efficiently, so the intraocular pressure increases. As opposed to closed angle, where it doesn't drain at all. and the specific precipitating factors. So with open angle glaucoma, a lot of text here. Who really cares? The important things that increase age. A risk factor for any sort of person with glaucoma is increased age. And it's insidious. It doesn't do anything until maybe it's too late, or because the brain can compensate for the changes. And the important thing you'll see on the fundus is you're looking at the cup to disc ratio. So I guess it's best seen visually. So this is the cup. So remember, the cup was this little area where the optic nerve splits into its ganglion cells. It's not really like, just like this. It's kind of all over the place. So if you think about it as a cone and it just splits everywhere, that's the disc. And as the intraocular pressure increases, this disc gets wider just because there's more pressure on that area, and it actually dies. So the cup widens, and a very high cup to disc ratio, a very low cup to disc ratio is very severe glaucoma, okay? And as this problem worsens, you get more visual field problems. So it's initially peripheral, and then it becomes quite severe. And because it's such a chronic process, a lot of patients don't notice it. And here you have a couple of kids playing with a ball, and as your glaucoma worsens, you might not even see the kids because you have this neuroplasticity in the brain. Some would say, is it a big deal? Kids are playing on the road, natural selection, maybe let them go. That's probably not the MUMIS approved view of pediatrics. So we'll go with one to save the kids. So it's a very dangerous problem, okay? So again, driving is another thing you want to consider with these patients. They might not even know they have the problem because just the brain is so plastic. So closed angle glaucoma is a little bit different. I think it's best seen with a picture. So this is our normal eye, and our fluid drains kind of through these areas and around the iris and the pupil, and then back into the anterior chamber of the anterior cavity. If the pupil is plastered against the posterior iris, like it is here, I don't know what my thing was. So if the pupil is dilated for some reason, if you're in a dark room watching, TV or something like that, and it gets plastered, i.e. a posterior sneaky eye, what happens is that the fluid can't drain anymore, okay? And if it can't drain, what's going to happen is that the iris will just move up because all the pressure is building up here, so the iris can only move one way, and that's anteriorly. And as it does that, there's going to be a pressure gradient, and that means it's going to move up, which is great, which means it can drain here, but then it's blocked here, right? So that's the problem. So the problem isn't that it's blocked here. That's the initial problem, but it can move up, and now it's blocked here. An acute angle blockage of the trabecular meshwork, okay? As opposed to open angle, which was just this chronic process grumbling around, no precipitating factor. These patients, who often do have open angle glaucoma initially, suddenly have this precipitating factor, and the iris moves up, and it's an acute blockage, and it doesn't move back down because the pressure is so high already. There's so much fluid, and none of it can actually get out. So the pressure increases massively. That's going to do major damage to your optic nerve. Does that kind of make sense? Yep. So acute closure. Patients might describe, right? So these and halos and stuff like that, similar to a cataract, but it'll be unilateral in one eye, and the examination findings will be there as well. So the examination findings were that the classic mid-fixed dilated pupil, and it's dilated because it's dilated so that they're watching TV at night, for example, and it just continues to be dilated because it can't go back to its normal size. So that's the reason why it's dilated. And the increased ocular pressure might resemble an orbit that's like a rock. I think you've got to be quite experienced to make that call. But there you go, that's a buzzword. How to manage it? The person who did the lecture last year emphasized this a lot. I didn't really learn it, and I passed the via, so I don't know if you want to learn it majorly. I think the important drug to remember is something like maybe drop a couple names, like pilocarpine is one that they want you to remember because it's on the golden eye rules, so that's one worth knowing. Just pick another one at random, maybe someone from this category. And know that you can do surgery as well. But the specific management, I think, is a little bit too complex because really you want to be referring to the ophthalmologist. And they kind of try these drugs every minute or every 30 seconds, so it's quite specific management. Yeah, they mentioned pilocarpine, so I'll just go with that one. So the key differentiating point between open angle glaucoma and closed angle glaucoma. Open angle is chronic, it's bilateral, it's insidious. You don't know it's there until it's too late. You kill kids on the road. And you have this gradual field loss that you don't notice, and increased cup to disc ratio. It should just be decreased. Anyway, whatever. And in the closed angle, it's acute, usually a response to a precipitant. The dark room is very classic on exams. They get redness, they get pain, nausea, vomiting. The headache can go all around the eye, not just in the eye itself. Unilateral headache, the visual acuity gets decreased suddenly, and similar cup-to-disc ratio findings, and a very, very high increased intraocular pressure. And this is kind of all the causes of a red eye in the table that I think you can go through later. All right, so some going back to real third-year stuff. So who are we up to? Back to Michael. So if we have a complete transection of one optic nerve, and I've given you the whole pathway there, so you can cheat. What's the size of both pupils? Just like in a room. Will they be the same? Will they be, one will be larger than the other? And if so, which one? I'll implore you to pick a different answer from different. Yes, good. Yes, say it confidently, you know? They'll be the same. Why will they be the same? Because one optic nerve is fine, and you have the concentric light reflex, okay? So just to think about it, room is just light. It comes down one optic nerve. It kind of has this partial decussation across both lateral geniculate bodies, the Edinger-Westphal nucleus. Who cares about those names? We just know that it goes bilaterally, and then it supplies the parasympathetics, which run along the third cranial nerve on the periphery, and that supplies the constrictor, okay? So they'll both be the same, constricted or dilated, depending on how the room is. They'll be the same. And it's worth knowing that pathway. Those are just the muscles. I'm not going to go over it much. What if you had both done? Both optic nerves completely transected. What do you reckon will happen? Our social VP guy. Yeah? And will they constricted or dilated? Yeah, you'd be correct. You have my vote. Are you going unopposed though?
I have no idea.
You have my vote anyway. So both dilated. Good, because there's no parasympathetic activity to either of those muscles, so they're all going to be dilated, right? The dilation is based on sympathetic activity, which is why when you have a Horner syndrome, that the pupils are constricted. Right? No parasympathetic activity. The parasympathetics are part of the third cranial nerve. The cranial nerve 3 has sympathetic and parasympathetic parts. Yeah. So the parasympathetics are mainly along this. It's these fibers here. They're on the periphery of the nerve, and the rest is just sympathetics. So what if we have a partial lesion, i.e., demyelination of one optic nerve? What will happen if we shun the light on the normal pupil? So if we had this nerve was demyelinating for some reason, well, if we shine light on this one, what will happen to both pupils? Yeah, they're both constrict evenly, good. And part 2 of the question is, what if we shine light on this pupil now? Yeah, they'll just constrict less, right? And if you remember back to third year, you did that the swinging light test, and you put afferent pupillary defect. This is what this patient would have, a Marcus gun pupil, and you put the light over the affected pupil with that has the demyelination or the optic neuritis. What happens is that it actually looks to be dilating, but it's just going to constrict slower. If you have the light on there for long enough, it'll constrict, not to the same degree as the other one maybe, but it'll still constrict. It just constricts slower, so it looks to be dilating as it's accommodating to constrict. Accommodating was the bad word to use there, but just constricting. That's important. So here we've got a young woman, and I'm not going to make you interpret the MRI. A young woman presents with loss of vision and pain in one eye. Fundoscopy is normal. Who are we up to? Yeah, we'll go back to you. So just from the 2 sentences I've given you there and what I just talked about in the last question. Young woman, loss of vision, pain in one eye only. Fundoscopy is normal. Classic third year question. It's painful. She's got black and white vision, pain on eye movements maybe, maybe not. She's got the rapid afferent pupillary defects, and it ends with neuritis and it starts with optic. Yeah, optic neuritis. Yeah, good. Say it confidently. So if we look at this MRI, I'm just going to show you just because I want to get a learning point here. So this is a T2 MRI. You know it's T2 because the white matter is darker than the gray matter. What else would I be looking for in this MRI if I knew a patient had optic neuritis? Anyone? Does anyone remember the diagnostic criteria for MS? Does anyone remember what it's called? Yeah, exactly. So you'd be looking for other lesions, right? So you'd be looking for infratentorial lesions, juxtacortical lesions, juxtaventricular lesions. And this patient's got none of those if we just scroll through quickly. The MRI. So optic neuritis. So as you would have learned last year, inflammation of the optic nerve. Think about MS. If it's unilateral, if it's bilateral, think of that weird condition, neural myelitis optica, defects disease, aquaporin 4 problem, that somehow it doesn't affect the aquaporin 4s in the kidneys and the gut. And remember, it's got that rapid afferent papillary defect, right? That's pretty characteristic on an exam. Remember that one. Fundoscopy is usually normal, right? As opposed to papilledema, which is an important one to think about. And here it is. So a middle-aged obese woman has been suffering from worsening morning headaches for the past 2 months. What do we think? Yeah, benign intracranial hypertension, pseudo tumor cerebri, whatever you want to call it. So this is what happens as the papilledema goes up. This is a shitty quality, but as it goes up, you can see that the optic nerve gets pushed in because of all that intracranial pressure. You've got to remember that the optic nerves are really extensions of the brain. They have a dura, so everything that's coming into the optic sheaths and into the optic nerve is the same pressure that's from the rest of the brain. And it really pushes the optic nerve out, which gives it that blown up appearance as you look at it on the fundus. Again, this is a fundus that can be an OSCE, but it's so characteristic. So if we look at the picture, the fundus looks blown out, right? So blurry margins, we don't know where the disc and cup starts. We can't see any of that. It's very blurred margins. That's the key thing that you want to look for. And it makes sense that it's blurred because it's being pushed anteriorly. So it looks like everything's blurred and mushed and smushed up together. And if it's unilateral, think of a frontal lobe tumor. Probably too much information. So what about this patient? Spot diagnosis. Pathology is in this eye, this eye. Yeah, why do you say Horner's? Horner's got 3 features, 2 of which you can see. Yeah, good, absolutely. Yeah, it is. Yeah, they've got ptosis and they've got meiosis. Can't really see the anhydrosis, but you assume it's there. And there's a lot of causes of Horner syndrome. Do you need to know them? Absolutely not. The ones you need to know are just one of each type, each order of neuron. So the lateral medullary syndrome, which is the one that you would have learned a lot about in 2nd year, and again in 3rd year, the other symptoms of a lateral medullary syndrome. I mean, the answer is inevitably no for most people, but it should be yes because it's a very oscable. Sorry, and it's a very examinable condition of the bio. That question is worth like 1/3 of an MCR from last year, so it's quite a serious deal. That might be news to people, but it's not my problem. So, anyone remember any symptoms of a lateral medullary syndrome other than Horner syndrome? Does anyone remember the 4 things on the side of the brainstem that start with S? So, with the spinocerebellar tract, the spinothalamic tract, the sensory tract of the 5th nerve, and the, I don't know, can anyone remember the other one? I'm forgetting. Oh, the sympathetic, see what you could call Horner syndrome. And then which cranial nerve nuclei will be affected? So remember the 4s. So 4 in the midbrain, kind of, 4 in the pons, 4 in the medulla. So the last 4 in the medulla are 9, 10, 11, and 12. So which ones will be in the lateral part? The ones that aren't divisible by 12, right? So 9 and 10. And 11 kind of has a cervical supply, so it doesn't really count. And then remember that the vestibular tract is also in that area, in the lateral medulla, so vertigo as well. Those are your lateral medulla. So you've got to go over that stuff. That's why I'm doing this. Other things you want to remember are Pancoast tumor, 2nd order neuron, and ICI dissections as well as a 1st order neuron. Those are your 3 causes that I'd suggest remembering out of all the crap that I've written on the slide. And picture, because everyone likes pictures. Right, so moving on to actual visual field defects. Again, third year revision, they can show you these pictures, not unreasonable. Who are we up to? Yep, the one who doesn't want to answer the question, but you should know this one. So this is a very characteristic lesion. You learned in endocrinology, which is a weird time to learn any sort of, yep, what were we saying? Yeah, absolutely, and cause? Yep, such as? Yeah, pituitary macroadenoma, yeah, absolutely. What about this one? Yep, good. Cause? Or where's the lesion? So if it's on the right, so it'll be on the left. And it's up, so it'll be down, temporal lobe. Yep. So just reverse everything because the optic fibers cross not only left and right, but also up and down. Good. What about this one? So we'll go back up. Yeah, to the person who was just yawning. Yep. Yep, on the right side. Yep, good. Where's the lesion? That's right. Anyone know where the lesion is for this one? So usually the tip of the occipital lobe, okay? So occipital infarct, that's because the occipital lobe has MCA and PCA supply. So if you knock out the PCA, the occipital stroke, you'll usually, okay, which is good in an evolutionary sense because the macula is the most important part of your vision. Defects. I thought it's quite nice because it's 3D and it just looks different. So what about this one? This one's not explained by the nerves, but it's also an important one to recognize. It's a very important GP condition that you learn. Well, it does to do with the optic nerve itself, but nothing behind that. Like all of this crap, not relevant. It's this one here. Where the optic nerve might die. This one half. Yeah, optic neuropathy. Yep. Do you know any important conditions that can cause optic neuropathy? Any conditions that can cause blindness that you might want to not miss on a GP station? Say if they got a headache and they got jaw claudication, temporal arteritis. Absolutely. Say it with confidence. So temporal arteritis. So this is anterior ischemic optic neuropathy. The name is great, but you don't need to know that. What you need to know is temporal arteritis is the thing you want to rule out. So unlike all the other conditions where you look at the midline in a vertical sense and then look at quadrants and stuff like that, these patients will have a defect that's altitudinal, right? Horizontal defect. Why? Good question. It's because of the nerves here. The arteries here supplied from the top and from the bottom. Okay, so these posterior ciliary arteries are supplied from the top and the bottom. So if you knock either one of those out, you'll get death of an optic nerve in a horizontal sense. Okay, so it's a vasculopathy causing a neuropathy. And that's very common in temporal arteritis, which not only affects the temporal artery, but also the carotid arteries and all the branches. Although it's technically classified as a medium vessel vasculitis, it also affects small vessels as well. So how would you rule out a GCA, giant cell arteritis? How would you rule it out? What's the diagnostic test? Not diagnostic, what's the first test you do? Yeah, ESR, and then would you do a biopsy or would you do something else? No, yeah, start them straight on methylpred or pred, very high dose, and then do the biopsy later. Biopsy you might not get because vasculitides don't affect the vessel uniformly, so you might miss, right? So you got to do a few spots of biopsy. We'll skip this one. So cranial nerve problems. So there's 3 cranial nerves that involve eye movement. So the person who's got the third one can't get it wrong. So this one. Yeah, absolutely. A left cranial nerve 6 palsy. Those are the 3 money shots. What's the important thing you don't want to miss out with the 6 nerve palsy? Important predisposing problem. Yeah, absolutely. So a tumor causing increased intracranial pressure, which I don't think that's what you meant, but we'll go with it. I'll give you credit for it. So the reason for that is because the nerve comes onto the clivus. It's a very acute angle for a nerve, 9 degrees. as the brainstem herniates downwards, this is going to get pulled, causes a sixth nerve palsy. That's the theory behind it. So sixth nerve palsy, the one thing you want to rule out is a mass in the brain, a bleed in the brain, something causing increased ICP. What about this one? Just moving along. We've got 2 nerves to choose from, so 3, yeah, good, absolutely. So there's a few problems here. So ptosis, which gives it away basically, and the pupil's kind of out. It's not really down. It's not a perfect example, but the rest kind of makes sense. Now, talking about cranial nerve 3 palsies, the reason I mentioned why the parasympathetics are on the outside of the nerve is because if the parasympathetics are involved in the cranial nerve 3 palsy, it means you have something pressing on the nerve. And that's bad news, right? That's usually an aneurysm. And aneurysms can burst and cause a whole lot of shit that goes wrong. So pupil dilated is an emergency, which means the parasympathetics are involved, hence the eye is not constricting, okay? And if it's not involved, that means it's probably a microvascular problem like diabetes, which is a common cause of a third nerve palsy or any nerve palsy. So that's important to know. Key differentiating point for the exam. What about this one? So I've done 2 of the nerves. So last nerve. Yeah. Do you want to tell me why it's cranial nerve 4? Just like if you know, because cranial nerve 4 is hard to pick. What does cranial nerve 4 do when you test for it? So let's say you asked to do an eye exam in your OSCE, not unreasonable, and you did the eye movements.
Down and then in.
Yeah, down and in. Yeah, absolutely. So with this patient, it's got a few things wrong, but these are the 2 money shots, and maybe this one as well. So money shot's probably not the most appropriate word. I'll go with it. So this eye is not going as well as this eye in terms of going in and down. That's hard to pick. The other things that are important is look at this. This eye is shooting up here when this eye is moving just completely laterally. That's because cranial nerve 4 does intorsion of the eye, and if the eye can't intort, it's going to do this problem. There's also a head tilt. So I think the head tilt is worth understanding to some degree, because in case you've seen in real life, not so much for the OSCE. So let's say you have your 2 eyes like this, right? And this eye is a bit screwed up with the cranial nerve 4. So that means it can't intort. So it's going to be a bit like this, yeah? I'll just move around so everyone can see. So as you move your head this way, what's happening is that your eyes are going to be like this, but your vision doesn't become like this either, does it, right? Your vision stays straight. So what's happening is that one eye will export and the other eye will intort. Okay, and you can do this in the mirror if you look at certain vessels in your eye and do this and this. You just look like a bit of an idiot, but it works. So you do this and it works, right? So this is why patients will have a head tilt away from the lesion. If they move their head this way and the eyes are like this eye will be able to intort back, extort back, but this eye won't intort, right? Because the intorsion doesn't work. So as they put their head like this, they'll get more double vision, more dizzy. So the automatically default is slightly tilted away so that the eyes are kind of straight and more extortion on the affected eye. Does that make sense? Yeah, so it's important to think about, and if you look in the mirror, focus on some capillaries in your conjunctiva and do these things, you'll get a good neck workout, and it'll also make sense. So that's why they get the head tilt, and that's why one of the eyes is shooting upwards. So the most common reason these patients complain, how would they present in an EMQ? How do they present an EMQ? They can't look down. So reading, right, climbing like down the stairs, that sort of stuff, they can't look down for a long period of time because one eye just shoots back up. So that's the problem now, okay? Important to recognize that, so you don't have to memorize it, you'll understand it. And if you have a deeper understanding, it'll all click much easier. And this was worth knowing last year, to some degree. I can't say how. So these are the movements. You need to know that for your OSCE because eye exam is GP, so they could do it in an actual exam. And GP does weird exams. They do physical exams, unlike the other ones, which just don't. So key differentiating point, 3rd nerve, you want to rule out an aneurysm, down and out pupil. 4th nerve, it's just shooting upwards a bit. Usually no sort of major problem to cause that. 6th nerve, you obviously can't abduct the eye, and you want to rule out increased intracranial pressure, okay? Key differentiating points. All right, what about this patient? So this is a child, they're at rest, they've got no cranial nerve problem. Who are we up to? One of you guys. Yep, you want to take it? Yep, so a type of strabismus, right? Yep, so good. So strabismus is just a misalignment of the eye, not due to any cranial nerve pathology, just due to congenital causes usually. But obviously you want to rule out cranial nerve pathology. You don't need to remember the specifics of this. Just know that it can be treated, and if you don't treat it properly, you get amblyopia, so you get a lazy eye, so where your vision kind of focuses through one eye only. You have to treat that with like a patch and things like that. How to test for this, and this is worth knowing for the EMQ because it may or may not have come up, is when you shine a light in one eye, it doesn't shine off the middle of either eye, okay? And that's important to know. That means the patient's got strabismus, and it's in the eye that it didn't shine off the middle of. So you just put a pen torch at just 30 centimeters in front of them, and it should line up evenly, center of the vision. Unlike this patient, so what's this patient got? Small eyes. Yep. So the diagnosis is Asian. Sure. Not that Asian is any sort of bad thing, but this patient's got pseudostrabismus, right? So the light is coming off the middle of both eyes, and he's just Asian. He's just an Asian kid, and they just get better. It's because of the skin fold here. It just makes it look like that it's wrong, and it's not even racist. Like, there's no other way of putting it. Like, this guy's obviously not Indian, right? He's obviously Asian. It's putting it out there. It's because of these skin folds, so it just looks like there's a problem because you can't see the sclera on the other side, but it's actually not a problem at all. Just normal eyes, and as he gets older, it'll just look like anyone else. Hopefully that was politically correct enough. Yeah, more common in Asians, I wrote it down. It's a true thing. It's a legit thing. I'm not making it up. What about this patient? So a GIF. Oh, it's got some crazy party trick going on there. You at the back. Oh, yeah, you want to go for it? Yeah. So his eye is having some nystagmus as it looks towards one side, and the other eye can't adduct. Longitudinal fasciculus, yeah, good. That's the hard part. Do you know what it's called? Intraocular ophthalmoplegia, yeah, INO. When you want to think about it as a unilateral thing, it's probably a stroke. Bilateral is probably MS. That's probably like the best case of INO you'll ever see. It's so obvious. So what's happening with INO? This is a complicated diagram, but maybe I'll leave it out so you guys will not get scared. But basically what happens is that if you think that your sixth nerve is the one controlling your vision when you're looking laterally. So if you look this way, the sixth nerve nucleus is sending a signal through into my third nerve nucleus on this side via the MLF, okay? So if I have a problem with this eye, and I can look this way because this sixth nerve nucleus can connect via the normal MLF on this side, right? So both eyes will look this way. But if I want to look this way, this sixth nerve nucleus can't make this nerve, can't make this third nerve move in. So this nerve will stay there, the eye will stay there because the third nerve won't work, and this eye will kind of keep trying to pull it from the nystagmuses. So again, MLF on this side is the problem. If you look this way, it can, because this sixth nerve and this MLF are normal. It can't look this way because this sixth nerve is normal, this MLF is not normal. Okay? And the picture's all there. So the sixth nerve goes straight to there via the MLF to the other eye. Okay? So again, if I wanted to look the direction that this patient's looking, I can't because the sixth nerve can't make the third nerve move medially. But if I wanted this eye to look this way, I can because this sixth nerve doesn't need the MLF on this side to make this third nerve work. It just needs the MLF on this side. Does that make sense? You need to think about it a bit, but it has to make sense. You guys are smart. So I can't explain it another time because I just don't want to. So what about this patient? So this is at rest, and this is with eye supplied. So who are we up to? Person in the back. So you wouldn't get this in an OSCE, but you'll get the description of this in an EMQ. I think if you have a story to back up your descriptions and a picture in your head, it makes more sense. Absolutely. Myasthenia gravis. Yeah, good. Say it with confidence. Myasthenia gravis. So this patient's got fatigable ptosis of this eye. Does myasthenia gravis have to be bilateral? No. And this patient's got it mainly in this eye. And after you put the ice on it, it actually becomes better. You actually slow down the breakage of acetylcholine. So fatigable ptosis and the eyes becomes better. You treat it with the stigmine drugs, okay? Or you take out the thymus in a younger patient, as you'd know from third year. What about this patient? You know, giving you a death stare. We'll go to the person in the back behind Nadia. Unintentional weight loss, diarrhea, neck swelling, double vision when looking in certain directions, and they look like this. from the 1950s. Sorry? Yeah, more specifically? Graves, absolutely. So you don't get ophthalmopathy in other types of hypothyroidism, okay? The Graves' disease. So to make a long story short, the problems with Graves' disease is that you have too much fat and you have the muscles become larger. So too much fat, muscles become larger. The problem with Graves' disease is that it compresses the optic nerve and kills it off. Okay, that's the reason why Graves' disease is a big deal for the eyes. The muscles become big, which means they can't work as well. But too much fat means that the eye gets pushed forward, lots of swelling everywhere, and the optic nerve gets compressed. The eye dies. Solar flex there, mate. So the symptoms you get are lid lag and retraction, as you know. So retraction just means that the eyelid is pushed back, as you'd imagine with someone having a massive stare. Chemosis, which is swelling of the conjunctiva, and you get swelling everywhere else as well. Last one, case 50. We made it. Who are we up to? Yeah, varicella zoster. Yep, absolutely. So which nerve is it affecting? Yeah, the ophthalmic division of the trigeminal nerve, i.e. V1. So herpes zoster ophthalmicus. You can also get maxillaris and mandibularis as well, but they don't cause this problem. The reason why this is a problem is that, remember that I said that the eye is also supplied by the fifth cranial nerve, and you can get keratitis. So any problem involving V1 can also affect the eye, and that causes really big problems. Important sign to know for the exam is Hutchinson's sign. Is worth knowing for the EMQ, just to know. It involves the tip of the nose. That's very characteristic of V1 involvement. If you remember your nerve roots, the external nasal nerve, I mean, who remembers these anyway? But the external nasal nerve actually is part of V1, so that's kind of the explanation behind it. So I think that's it. If you have any other questions, so what I've got left is I've got a few extra cases that I kind of not really need to know. And then I think what's worth knowing is the next video. So the next video is on fundoscopy, and it's the one that they recommend to you on YouTube. So I've just put it here so that you guys know to remember to look at it, because it's done by these British people. It's actually quite a good video, and most of us don't have ophthalmoscopes at home, so it's kind of worth refreshing your memory on how to use a ophthalmoscope and looking at the 4 arcades and all that sort of stuff. And it's someone knows how to do it and someone doesn't know how to do it. That's probably all I have to say. So I think you got, what, 69 days until your exam? I was going to put up a big number saying 69, like, what's the relevance of this? But I would have got some weird answers. So I'm just going to say it. So you've only got a few more months, but I think you've got enough time. 3 months is more than enough to learn everything in 4th year if you really put your mind to it. That's when most people kind of start. If you haven't done OSCEs in groups, you have to start now, because there's too much shit to remember by yourself, and you can't practice by yourself. It's just sad and depressing. So make sure you get groups of 2, 3, 4 people, start practicing, do EMQs, get BMJ. You can buy a 3-month subscription. Google the discount codes if you're a discounting type of person, like most of Med is. And just make sure you do it well. Any questions at all? No? All right, good luck, guys. I'll see you next year in final year. Yeah.